Everyone, welcome back to this last chapter of Death and Dying. So across all age groups in the United States, mortality rates have steadily declined. Since 2005, infant, neonatal, and postneonatal mortality have decreased by approximately 15%. However, there are significant disparities that remain. So, Black non Hispanic infants experience mortality rates nearly twice as high as Hispanic and non Hispanic white infants. Similar racial and ethnic differences are also observed in overall life expectancy. The causes of death vary across the lifespan. So, in infancy, genetic conditions, prenatal complications, and birth related issues are the most common causes. During adolescence and young adulthood, unintentional injuries account for the majority of deaths. In middle adulthood, cancer, heart disease, and injuries become the top three causes. Accidental suffocation is most common in early childhood. Unintentional poisoning is the leading cause of injury related death between ages 25 and 64. Now we're going to define what death is. So there's death with dignity, which refers to supporting individuals in dying in a manner that aligns with their personal values, preferences, and desired level of control over their end of life care. Historically, clinical death was defined as the moment when the heart stopped beating, but now because we have advances in medical technology, these have led to expanded definitions of death. And so today, whole brain death is the irreversible loss of all brain activity, and that's the widely used term. Criteria include a flat EEG for at least 10 minutes and the absence of motor reflexes. Then we have it's called a persistent vegetative state. And this occurs when a person appears awake, but they lack awareness due to permanent loss of cortical functioning. Individuals in a PVS state remain biologically alive, and an estimated 30,000 patients in the United States are maintained in this condition. But most importantly, PVS is not legally considered death under US law. Planning ahead is an important part of dying with dignity. So, advance directives help make sure a person's wishes about medical care are known and honored if they cannot speak for themselves. Many people have a living will, which is a legal document where somebody writes down what medical treatments they do or don't want if they become too sick or injured to communicate. The second is a durable power of attorney, and this is a document that allows a person to choose a trusted family member or a friend to make healthcare decisions for them if they become unable to decide on their own. Making these decisions ahead of time can reduce stress for loved ones and help ensure a smoother end of life process. Despite their importance, advance directives are still not used often across all age groups. Euthanasia refers to helping a terminally ill person die more quickly, and people can use a living will to outline when they want life prolonging treatment stopped and whether euthanasia is acceptable to them. There are some court cases that have been controversial, such as the landmark Nancy Cruzan case. They have shaped the right to die movement. After a severe 1983 car accident left Nancy in a persistent vegetative state, her parents requested the removal of her feeding tube. And the case went to the US Supreme Court, and they ruled that families may refuse treatment in extreme situations if there is clear evidence of the patient's wishes. Testimony from Nancy's friends and family provided this evidence, and her feeding tube was removed in 1990. Euthanasia is typically categorized as passive. It allows for natural death by withdrawing treatment, or it could also be active, and that involves deliberately causing death with medications. Most US adults and physicians support passive euthanasia in some situations, and many say they would refuse treatment if they were in great pain, had no hope of improvement, or were completely dependent on others. About a third of adults say that they would want every possible life-saving measure, even in very severe situations and conditions. So decisions about euthanasia are deeply personal and they can be very emotionally complex. There is no single solution that works for everyone. Physician assisted suicide is a form of voluntary active euthanasia, and this is when a terminally ill person chooses to end their life with the help of this physician before the dying process becomes prolonged and painful. This practice has been legalized in several US states, and it began with Oregon in 1997. Before it became legalized, Dr. Jack Kevorkian became widely known for illegally assisting more than 100 terminally ill patients in ending their lives, and this ultimately led to his arrest and conviction for second-degree murder. People who pursue physician-assisted suicide often cite three main concerns, and one is being unable to participate in activities they enjoy. The second is losing their independence, and the third is experiencing a loss of dignity. So, despite growing acceptance in some of the states, physician assisted suicide and euthanasia more broadly, it continues to be a deeply debated and controversial issue. Hospice care is designed to help people die with dignity and as comfortably and peacefully as possible. Instead of focusing on curing illness, hospice focuses on improving the quality of life for patients by managing their pain and providing them emotional, spiritual, and social support. There are many people that die in hospitals, and most say that they would prefer to die at home, that be surrounded by loved ones. And so hospice care begins when a patient and their doctor agree that the illness is terminal and that further treatment will not lead to a cure. Hospice can take place in a specialized inpatient facility, and it's often provided in the patient's home, which is becoming increasingly common because it is more cost effective that way, and it allows people to remain in a familiar environment. Home hospice is linked to higher satisfaction for both families and their patients. Whether care is at home or in a facility, the hospice team is usually doctors, nurses, social workers, and spiritual or grief counselors, and they work together to support the patient and help loved ones cope with the end of life process. Different cultures understand and respond to death in different ways. In some South Pacific cultures, death is not seen as completely separate from life. Other cultures, like the Kwanga of Papua New Guinea, they attribute most deaths to magic or witchcraft. Ancient Egyptians practiced elaborate rituals like mummification to prepare for the afterlife. And so they believed that the body needs to be preserved so that the spirit could live on. Many cultures also have specific rituals for caring for the body after death. So, for example, the Bornu of Nigeria wash and they wrap the body in cloth. And in the French West Indies, neighbors clean the body with rum. Some Native American groups, like the Hopi, view death as just one part of a continuous cycle of life. In South Korea, there's a traditional ritual called the Agu Cut, and it involves a shaman helping the family express grief and guiding the spirit to peace. Religions around the world also have differing perspectives. So Hindus emphasize a holy death, and Buddhists focus on insight and reincarnation. Christians view death as an entry to heaven or hell, and Muslims see death as closely connected to life. So many cultures also believe that some part of a person, such as the spirit or soul, continues after physical death. In Western cultures, people are considered to have a mature understanding of death when they grasp four key ideas. One is that death is irreversible. The second is death is inevitable. And the third, it involves the end of bodily functions. And lastly, death happens to all living things. So now we'll briefly cover children's understanding of death. Children encounter death in many different ways throughout their early years. They may experience the loss of grandparents, parents, siblings, friends, or other important adults. And for many children, the death of a pet is their first significant experience with loss and grief. Pets often represent unconditional love, so their death can feel deeply personal to a child. Beyond personal experiences, children are exposed to death more often than adults realize. They overhear conversations about deaths of relatives or public figures, and the media coverage frequently includes reports of accidents, homicides, natural disasters, and war. Events like the COVID-19 pandemic brought widespread discussions of death into homes, and some children face the death of family members firsthand. Because play is how children process and understand their world, it is common for death-related themes to appear in their games, stories, and rhymes. Children may act out car crashes or battles with toy soldiers, and traditional songs and fairy tales often include death imagery, such as the falling cradle in A Rockabye Baby or the wicked stepmother demanding Snow White's heart. These themes allow children to explore fears and questions about mortality in a safe, imaginative way. Children's understanding of death develops gradually. So, young children often see death as temporary or reversible, and they believe that people can come back to life through magic, prayer, or medical care. They may describe death as sleep or a journey, and they sometimes personify it as a figure that takes people away. Before they grasp the concept of non-functionality, they may think that dead people still feel hunger or emotions. They also believe death can be avoided by being clever or lucky. Having a mature understanding of death means recognizing that death is irreversible, inevitable, and involves the end of bodily functions. By ages 5 or 6, most children understand that death cannot be undone, and by late childhood, they typically comprehend the biological nature of death. And so this progression occurs across cultures and is closely linked to advances in abstract thinking and executive function. Children's understanding of death is shaped by many factors, and this includes how much they are exposed to death and how the adults in their lives talk about it. Around age 3, children begin asking questions about what death means, but their understanding varies widely across cultures. For example, many European American parents tend to shield children from death, while in other cultures, children may receive more direct explanations based on biological or religious beliefs. As children grow, they can hold multiple and sometimes conflicting ideas about death at the same time. By adolescence, young people often see death as both inevitable and sometimes as nothingness, and their growing ability to think abstractly increases their interest in the deeper meaning of death. Adolescents often describe death as an abstract state of nothingness, and they understand that death marks the irreversible end of biological life. As they go through puberty and physical changes, they do become more aware of life's biological limits, but their awareness doesn't always translate into safer choices. So many teens will still engage in risk-taking behaviors because they have this personal fable, which means they have a belief that they are unique and unlikely to be harmed, even by something as final as death. And at the same time, their growing ability to think abstractly deepens their curiosity about what death means and whether any psychological experiences like thinking or feeling continue after the body stops functioning. Across cultures, adolescents often hold both scientific and spiritual explanations for death, and they believe in an afterlife, but they also understand the biological finality of death. And so these dual perspectives can be used flexibly depending on the situation. So, for example, among the Vezo people of Mascadar, adults believe that ancestors remain present in daily life, guiding and watching over the living. The Vezo children tend to rely mainly on biological explanations for death, but adolescents and adults integrate both biological and spiritual beliefs, and they show their ability to hold multiple perspectives at once. So now we're going to cover adults' views of death and how they perceive it. So adults' views of death change gradually throughout life. And young adults start to apply their understanding of death to themselves. And as the personal fable fades, they realize they are not invincible. They take fewer risks, even though death still feels far away. In middle adulthood, people often experience the deaths of parents, friends, coworkers, and so this makes them more aware of their own aging and mortality. And oftentimes, this leads them to rethink their priorities and focus more on giving back or leaving a meaningful legacy. By the time people reach older adulthood, they have experienced multiple losses, and so they become more familiar with the idea that death is a natural part of life. Older adults talk more openly about aging and dying, and they think more about how they want their final years to look. Research shows that the fear of death usually decreases with age, and this is partly because older adults are better at managing emotions and may find comfort in religious or spiritual beliefs. In later life, people often look back on their lives, try to make sense of their experiences, and work towards feeling that their lives have been meaningful and well lived. So now we'll go over the dying process and the experience of death. So the dying process can look very different from person to person because the rate of decline before death varies widely, and this is called the dying trajectory. Researchers describe four common patterns. The first is an abrupt or surprise death, which happens suddenly with no warning. A lot of times this is an accident or a heart attack. And so the person seems fine until a rapid decline leads to an immediate death. The second is a short-term expected death. And this is where someone with a terminal illness shows a steady and predictable decline. The third pattern is an expected lingering death. And this is a slow, prolonged death process, and it's often seen in very old age or long-term frailty. The fourth pattern is called entry-re-entry deaths, and this involves ups and downs, which are periods of decline that are interrupted by partial recoveries, and oftentimes this leads to repeated hospital stays. And these different trajectories affect how both the dying person and their family cope. Short-term expected deaths are usually the most predictable, and they're often supported by hospice care. Lingering and re-entry patterns can be especially stressful for families because they last longer and hospice care often comes very late. So in the final hours or days before death, people tend to show certain predictable changes and symptoms. The number and severity of symptoms can vary widely depending on the illness and the dying process. So many people tend to lose their appetite. They may experience dramatic weight loss, especially those with long-term illnesses like cancer or neurodegenerative diseases. They can cause extreme muscle loss. And so as death gets closer, the person often sleeps most of the time. They may become confused or disoriented. They may have trouble seeing and even experience auditory and visual hallucinations. Physical symptoms can include pain, shortness of breath, irregular breathing, nausea, and problems with bladder and bowel control. Oftentimes in the near-death stages, people usually lose interest in eating, drinking, or talking. They may become very weak and drowsy. Breathing also becomes more difficult. People may produce a gurgling sound. It's called the death rattle. And this typically means that death is near. There is also fluid buildup, which can cause swelling, and there's psychological symptoms like anxiety, depression, confusion, and delirium. So people react to the news that they are dying in many different emotional ways, and there are stages of grief. So Elizabeth Kubler-Ross described 5 common reactions: denial, anger, bargaining, depression, and acceptance. All of these stages are not always occurring in the same order. So some people may experience denial and anger, and then they may experience depression, and then they may go back to denial. So not everybody experiences all of them in the same order, and not everybody experiences all of them either. At first, many people feel shocked and they may deny the diagnosis. They may convince themselves that it can't be true or seeking multiple opinions. But once the reality sets in, anger often follows, often with feelings of why me or resentment towards others who will continue living. Some people then move into the bargaining stage where they're hoping to delay death by making promises, or they might wish for more time. And as their illness becomes harder to ignore, they often become sad, depressed because of the loss that they're facing. Lost time, lost roles, and the knowledge that relationships and future plans will end. Over time, many people begin to accept that death is coming, and they may feel more at peace. They may withdraw slightly and focus on close relationships. So it's important to remember that dying is a personal experience, and emotions they tend to vary widely based on age, relationships, the type of illness, and the situation. So these stages can help describe common reactions, but again, people do not move through them in a predictable way, and many eventually reach a sense of calm as they prepare for the end of life. Children, adolescents, and adults understand death differently because of their different abilities and life experiences. So when children are dying, it can be hard for parents and doctors to talk openly with them about what is happening. Even so, children often learn a lot about their illness on their own through their experiences in the hospital. Research shows that children with life-threatening illnesses are often more aware of death than healthy children their age, and many show more maturity beyond what adults expect. So, in fact, even very young children, sometimes as young as 3 or 4, may understand more about their own approaching death than older, healthy children. Studies of terminally ill children have found that many realize they are dying long before death is near. They may show this by saying they won't be back at school or won't be around for an upcoming birthday. Some even say directly, "I'm going to die." And so many children keep this knowledge to themselves, and they try to protect their parents just as parents try to protect them. So now we move on to how adolescents experience death. So because adolescents have an ability to think abstractly, they understand death in a more mature way. So they have more mature conceptions of what death is. Their reactions are also shaped by the normal challenges of being a teenager. So they usually want to know the truth about their illness because they are developing a strong sense of independence. And at the same time, the typical teenage feeling of being invincible causes them to sometimes deny their illness or avoid treatment. And this is especially true when side effects can affect their body image. Spending long periods in hospitals can separate them from friends, make them feel different and worried about how others see them. They may have concerns about dating, peer rejection, or losing independence. Many adolescents feel angry and cheated about missing out on the future they imagined. And so, because autonomy is so important during adolescence, it helps when teens are included in decisions about their care. Dying adolescents especially need support that allows them to stay connected to others and cope in their own way. It's important for them to focus on the present and find meaning in their lives. Dying adults experience death differently depending on their stage of life. So oftentimes young adults feel angry and feeling that their life is unfair because they're losing a future they expected to have. And this is a time when people normally build close relationships, so illness can make it hard to form or maintain intimacy, and many fear being alone or abandoned. On the other hand, midlife adults grieve losing the present, so they may worry about leaving their families behind and not finishing important responsibilities. So they often focus on putting their affairs in order and finding ways to support loved ones even after they are gone. Older adults, however, have a full life to reflect on. So, although a terminal illness can make this life review more stressful, many older adults are more accepting of death and they feel they have less unfinished business to take care of. And they often want to strengthen family connections, make peace, and leave behind a meaningful legacy.